Good afternoon. I am Professor Shani Mahadev, the Academic Chair of the Equality, Diversity and Inclusion Committee at the Institute of Cardiovascular Sciences at UCL. It is my pleasure to welcome you all today on behalf of our Director, our ADI Committee, and my co-organizer, Shah Chowdhury, to this event to mark the International Women's Day celebrations. International Women's Day is normally set aside to celebrate the achievements of women and also to talk about the progress that have been made globally in terms of women's welfare. However, it's also a time for us to reflect on challenges that still face women in the world, and also to implement measures to address these questions. This year, the International Women's Day theme is Break the Bias. And in line with this, the Institute of Cardiovascular Sciences has been at the forefront of undertaking research to try and understand the basis of heart diseases and also to identify ways of effective treatment. In line with this, therefore, we have decided to organize this event to raise awareness of heart diseases in women, which has continued to be a problem that is hidden in plain sight. Joining us today, I'm really pleased to say we have a panel of specialists in their own fields who have kindly agreed to join us today and share their expertise with us in this panel discussion. I'm also privileged and with great pleasure, introduce our facilitator, Vivian Parry, OBE. She is a writer and a broadcaster who has had experience with science. She's done a science degree here at UCL. She's an alumni, obviously, and she is very keen at promoting welfare and well-being for women, having written quite extensively on health concerns. And as such, it is with great pleasure that I introduce Vivian to take us forward in leading the panel discussion today. Well, thank you very much, Vivian.
Shani, thank you very much. And if you're watching elsewhere, welcome to you. We have a top quality, small audience, but obviously very high quality here with us in the Institute of Education. And we have a wonderful panel. But first of all, we're going to hear from David Lomas, Vice Provost of Health at UCL.
Hello. I'm David Lomas. I'm the Vice Provost Health here at UCL, and it's my great pleasure to welcome you to this symposium, Hidden in Plain Sight, Heart Disease in Women, that's being organised by the EDI Committee of the Institute of Cardiovascular Science to mark International Women's Day on March the 8th. I'm really sorry that I can't be with you for this event, but I wanted to send this message. As many of you may know, I've been a trustee of the British Heart Foundation for almost 6 years, and I'm due to finish my term this year. The British Heart Foundation was founded in 1961 by a group of medical professionals who were concerned about the increasing death rate from cardiovascular disease. And as a consequence of the work of the British Heart Foundation, many academics and of course industry, there's been huge progress in this area, and now the annual number of deaths of heart and circulatory diseases in the United Kingdom has fallen around a half. Indeed, when I do clinical service, I don't see the sort of heart disease, and in particular the heart attacks, that I saw when I started in clinical practice over 35 years ago. Despite this massive improvement, there is still a huge unmet need of cardiovascular diseases in women. Cardiovascular disease in women remain systematically underdiagnosed and undermanaged on a population basis. This largely relates to misconceptions that cardiovascular disease is a disease of men, and women are usually underrepresented in research and clinical data. There's a failure to take into account female-specific risk factors of cardiovascular disease, such as a premature menopause, pregnancy-related complications such as preeclampsia and other ovarian syndromes that have led to poor outcomes of these diseases in women. So it's quite fitting that we highlight this in International Women's Day 2022. I'd like to finish by thanking Vivian Parry for kindly facilitating the panel discussion. I'd like to thank all the participants for giving their time, and I'd also like to thank Shani Budram-Madeo and the Institute of Cardiovascular Sciences team for all their hard work in putting together this important event. Thank you very much.
Under-recognised, underdiagnosed, undertreated. Those are the three phrases that you should remember for today. But Shani, start us off by telling us a bit more about the main overview of women and heart health.
Vivian, thank you very much. This presentation, I'm hoping, will actually just allow us to have a little bit of an overview, building on what our Professor David Lomas has already indicated, but also to lay out some of the issues that still continue to address women. I've been involved in research in cardiovascular diseases as part of the Institute of Cardiovascular Sciences, and my work, as with so many others, is supported by the British Heart Foundation.
So why has heart and cardiovascular disease remained such a problem for women? This is despite, as Professor Lomas mentioned, a better understanding of the risk factors and the disease processes have led to improved diagnosis and treatment, which have reduced, for example, death from heart attacks, particularly in younger men. To address these questions affecting women, the Lancet Journal launched a commission to investigate cardiovascular diseases, specifically in women. And the commission report, which was published in 2021, has helped to provide a comprehensive picture of the extent of the problem affecting women. This figure from the report clearly shows that cardiovascular diseases, including heart attacks and stroke, accounted for up to 35% of all deaths in women globally. The scale of the problem is also reflected in the yearly figure. In 2019, when the study was conducted, 275 million women were diagnosed with cardiovascular disease, and nearly 9 million women died from such diseases in that same year. This represents a significant increase when we compare with figures from 1990, when 6 million women were reported to have died of causes linked to cardiovascular disease. Therefore, it seems that although medical interventions have been successful in reducing death of men with such diseases, this is not reflected in populations of women. This has remained a major concern, mainly because the increased incidence and death of women with heart diseases are seen in younger women under the age of 65 years. So what are the underlying factors that drive such cardiovascular and heart disease in women? These are known risk factors such as hypertension or high blood pressure, which significantly increase the risk of developing heart diseases and stroke. Similarly, metabolic diseases such as dyslipidemia or high levels of LDL cholesterol, as well as diabetes, are known to increase the risk of cardiovascular disease and heart disease with poor outcomes. Yet recognizing such risk factors in women and implementing early treatment to prevent heart diseases have remained a problem. In addition, sex-specific and under-recognized risk factors, which will be discussed later, also contribute to the increased incidence in women. How does this compare with other diseases that affect women? In the UK, nearly twice as many women under the age of 65 have been reported to die of cardiovascular disease when compared with breast cancers. So you can see that there still remains significant problems which need to be addressed if we want to implement concrete measures that would help to reduce the global burden of heart diseases in women in the next decade?
So I thought that we can actually look at try and understanding this a little bit more by looking at some of the problems, and my colleagues, my esteemed colleagues in the panel will be emphasizing on some of these a little bit later. But there are a number of concerns. The first one, I think, it relates to the actual type of disease that this is. These are chronic diseases. For the healthy heart and blood vessel to undergo changes whereby you have a heart attack and eventually lead to heart failure and death, there has to be a number of changes taking place. And the nature of such chronic diseases is that they can actually develop over a long period, over decades, but they can remain at the early stages, they remain undetectable, which means therefore that they cannot be picked up and treated effectively at a time when you might be able to reverse these changes. And by the time symptoms arise, there is often very extensive damage and sometimes irreversible damage, which makes it a lot more difficult to treat. Although this is normally part of the aging process, it can be accelerated quite significantly by other diseases, such as obesity, such as diabetes. And there are a number of mechanisms that are associated with this, and these have been extensively studied. It is thought that such diseases might, for example, increase inflammatory responses in the cells, and that in turn leads to damage in blood vessels that would either cause blood vessel stiffening and hypertension, or atherosclerotic plaque formation, which will block the blood vessels and can then lead to a heart attack. The issue with the heart in particular is that the cells are not very easy to replace. They're very highly specialized heart muscle cells, and therefore scarring takes place. With that scarring, there is more pressure put onto the rest of the heart, and eventually the heart will fail. And that is primarily the course of the disease. So it is important, therefore, to recognize these issues. And a lot of scientists and clinicians are actually working on this issue to try and understand it in general. However, as was mentioned by Professor Lomas, heart diseases in women specifically have remained a concern because of the misperception of it being mainly affecting men. Heart diseases have continued to be understudied, under-recognized, underdiagnosed, undertreated. And one of the other key issues is that women have either been omitted or underrepresented in clinical trials that have been used to test drugs, for example, or interventions that can effectively treat heart diseases. And so because of these issues, there still remains a problem. Now, while it's understandable that estrogen does indeed protect young, healthy premenopausal women in terms of protecting the heart and blood vessels, this does not take into consideration other genetic factors that might predispose certain groups of women to heart diseases, or the effect of other conditions, such as hypertension and obesity, diabetes, smoking, lifestyle, sedentary lifestyle, all of which contributes to the disease. There are sex-specific risks, which hopefully the panel will be discussing a little bit later, but things like early menopause, pregnancy-related hypertension, ovarian syndromes like polycystic ovary syndrome can actually increase the risk of heart disease considerably. And similarly, and this probably relates a lot more to the more recent COVID pandemic, socioeconomic factors such as low income, psychosocial risks such as depression, all of those increase the risk of heart disease, and they disproportionately affect women. So that's some part of the issues. There are others that, again, as mentioned before, because a lot of the studies were focused on men, the symptoms of heart diseases and markers for heart diseases are generally agreed from observing men. And therefore, symptoms that present in women that might be different are not recognized. Similarly, differences in the causes of the diseases and other cardiac, heart diseases or cardiovascular diseases affecting specifically women do not tend to get considered, or they're not so fully understood because there has not been sufficient research done into them. Late presentation is a major issue, and because of these issues relating to symptoms and markers, women too tend to be 50% more likely to be underdiagnosed at first presentation to a clinician. Because of this, late treatment and diagnosis treatment can actually lead to up to 70% increase in fatality, in death of women suffering from a heart disease. And that has directly contributed to these poor outcomes. And then, as mentioned previously, the underrepresentation of women in trials means that the effects of drugs and how these might have the differences in women are not known. And these things need to be addressed. So what has been done about this? Again, with the Lancet Commission, there were some overarching recommendations were made. These relate mainly to understanding the disease process a little bit better, specifically in women, closing the knowledge gap, undertaking more research relating to that, enhancing awareness. And this is at a number of different levels, whether it's to the specialists, public health strategists, so that we can have things implemented, but also to the general public, so women are aware of the symptoms so that they can seek help at an early enough stage. The other one that I want to talk a little bit about how the research aspect is so essential in being able to address these types of issues. So, for example, in terms of current treatments that are being used quite commonly, things like calcium channel blockers and statins are being used to treat or to prevent heart diseases and cardiovascular damage. Those would only have been possible by understanding how calcium entry through specific calcium channels can actually cause hypertension, and how blocking that can actually then give rise to some therapeutic effects. Similarly, the same with statins, reducing high levels of LDL cholesterol is beneficial, and understanding that process was necessary for these types of interventions to be generated. But we still have a lot to do. We still need to identify markers of early damage. We still need to be able to then recognize and treat at an early enough stage. And then we also need to look at how the sex differences are actually, what the basis of those are, so that we can start looking at whether we can identify sex-specific markers to look at manifestation of these diseases, treatment, outcomes, etc. So there is still quite a lot to be done. And I thought I would just highlight some of the areas of, there are lots of research ongoing. This is just some aspects of our own research. We're looking at a master regulator that can control a number of different functions in cells. You could see that it's expressed in metabolic tissues like muscle cells and fat cells, where it is actually essential for controlling blood glucose levels, uptake of blood glucose. In immune cells, it controls inflammatory responses. In the heart, it actually controls contractility, adaptation to stress. And in the blood vessel, it actually is necessary for the contraction. And when we have loss, we can see that it manifests itself in a number of disease states. And we're still trying to find out how those are all linked together, because then we can be able to look at whether those types of master regulators, for example, can we actually look at how it affects male-female? We have actually identified differences in male and female heart following stress. So by understanding that, we know that it controls some of the estrogenic effects, and we can actually look at sex-specific markers and look at other potential options of treatment. So there is still quite a lot to do, and there are a number of different things that are ongoing already. These are just, the British Heart Foundation has actually launched a strategy some time ago in terms of just raising awareness of heart diseases in women, and also in terms of supporting research in this area. This has been covered quite a bit by the media as well, and that is the sort of thing we need to reach out to people. More recently, the European Society of Cardiology has also had guidelines for addressing it in Europe, so that we can actually aim to reduce cardiovascular diseases in women in the next decade or so, by 2030. And I'll leave it now because the panel, I'm sure, will have quite a lot to say on this. Thank you very much.
Shani, thank you so much. Terrific overview there. If you're watching at home, you're very lucky because it's very cold in here, and I'm sure you're very warm at home. So I want to introduce our top panel, and we're going to start there. So, Vikram.
My name is Vikram Talaulikar. I work at the Reproductive Medicine Unit in UCLH NHS Trust. I'm a menopause specialist for the British Menopause Society.
So this is your estrogen man.
I'm Charlotte Manistee. I'm a consultant cardiologist and researcher here at UCL, and I do my clinical work over at Barts. I specialise in heart failure and in patients who have developed cardiovascular disease as a result of cancer or their cancer treatments.
I'm Professor Amrita Ahluwalia. I'm a professor at the William Harvey Research Institute, which is part of Queen Mary University of London, at Barts Medical School, very long name, sorry. I'm a discovery scientist, that's what I like to call myself, a pharmacologist. And one of my major interests is trying to understand better what determines sex differences in cardiovascular function. And I do a bit of translational research, so I bridge the basic science, clinical science border.
Yeah.
Hi, I'm Gabby Kaptour. I'm an academic cardiologist based at UCL. I'm award free, and I predominantly perform research which revolves around cardiac imaging and population cohorts.
So you look at images of hearts?
Yes.
I'm Professor Kirsten Harvey. I'm at the UCL School of Pharmacy. I work in pharmacology, and I've got an interest in gender differences in all kinds of different organs, and I have a particular interest in teaching and training our students as well.
And Shani, you've already met, and I hope you'll chip in too. So I'm going to actually start with Gabby, because what I want to know is, do women's hearts look different? Are they physically different apart from being a bit smaller?
So I guess it's a rather tricky question, and it depends on what camera you use.
So that's a scientist answer, isn't it?
Fundamentally, I say that because if you use the Rolls Royce of imaging, which is what we tend to use in research, and that is predominantly cardiac MRI, which is what I tend to do as my day job in research. Cardiac MRI gives you some really exquisite high-resolution pictures of the heart, and when you are collecting such detailed pictures of the heart, a lot of research has now thrown up some rather impressive differences when looking at and comparing male and female hearts. And these are quite dramatic differences, starting from kids all the way up into older age. And there's a wealth of research being published showing that actually we are looking at two rather distinct organs. The heart of a man is rather different from the heart of a female, even in health. Let alone what disease does onto all of that.
So give us a quick example of
so
difference.
Lots of things. Male and female hearts age in different ways. The hearts of men and female tend to grow smaller in terms of their volume, but male hearts tend to thicken, whereas female hearts either remain of the same thickness or they become thinner with age, for example. There's been some research showing that, for example, male hearts look more coarse. They have a more granular texture when compared to female hearts. And there are also other differences in terms of the architectural pattern of the heart, muscle projections on the inner surface of the heart as well. We also know that there are differences in terms of the energetics of the heart too. Nowadays, using MRI, we are able to measure the vortices of how blood actually circulates within the cavity of the heart chambers. And there's been some nice work showing that there are important differences even in terms of the energetics and the way that blood is propelled around the heart chambers, even in perfectly healthy states. So this indicates that there are fundamental biological differences in the heart and the way the heart functions. And therefore this creates a very obvious substrate for why there should then be important differences even in the way disease and risk factors impact the heart in later life.
Okay, now there's also differences in the way that the heart works, particularly its electrical signals. Who wants to tackle that one? I'm looking at you.
But that's yes,
Charlotte,
fine.
I'm looking at you.
So we know that there are differences in the electrophysiology or the conduction system within the heart. And we know also that drugs can have slightly different effects on that. So with the other thing we know is that cardiac devices, so pacemakers, defibrillators, devices that help to improve the pumping function, or cardiac resynchronization devices, all have slightly different benefits in men and women. And in fact, cardiac resynchronization devices are more likely to have benefit to prevent hospitalization in heart failure in women than in men. And yet we know that women are far less likely to have one of these devices implanted. So there's definitely a bias when clinicians see a patient as to who they feel is suitable for some of these slightly more advanced or high-tech devices or drug therapies between men and women. And that's definitely going to impact on outcomes in men and women, with worse outcomes in women as a result of this difference in the way that clinicians perceive or are more likely to put patients forward for advanced therapies.
That's interesting, isn't it? There's a high-tech, low-tech thing here as well. You know that washing machines are designed by men because they've got 40 programs, but women only actually, who use the things, only actually use 3 programs. That's all I'm saying on that. So it's a big difference. So Vikram, let's look at the difference pre-menopause and post-menopause. What happens then to women that affects their cardiovascular?
Yes, so this is well known that women are protected by estrogen, that's the good hormone, before they go through the menopausal transition. And that transition can be quite long sometimes. So the actual menopause, when the period stops and 1 year beyond, maybe the final outcome that we look for menopause, but actually the changes in drop in estrogen start many years before that final period happens. So before menopause, estrogen protects from atherosclerosis, protects from the inflammation, and has endothelial actions on the lining of the blood vessels. And so you have cardiac protection. After menopause, the risk of heart disease in women catches up as close to men. And so therefore, the protection by the estrogen is lost by them. So one of the things in the recent times we've been looking at, especially through menopausal research, is how about estrogen being one of the factors that could prevent heart damage in women? Of course, it's a complex topic, and it's more relevant for women who have early or premature menopause, because 1% of women will have menopause before 40, which is quite significant, and about 10% will have it between 41 to 45. That's early menopause. In both those situations, these women will be left without estrogen for quite a length of time, where they're likely to start having some cardiovascular changes, which means they will be at a disadvantage when they get through their 50s and 60s. So there's a window of opportunity there, early menopause, perimenopause. If you're going at that point with estrogen, potentially you could give those women a bit of advantage. But I guess I'll come to that later in the discussion. There's so much.
So much to do. Let me turn to Kirsten, because Kirsten, you're particularly interested in gender differences in disease susceptibility. So is the disease susceptibility, again, different post-menopause and pre-menopause for all sorts of different diseases? And is that particularly pronounced in cardiovascular disease?
I mean, it's absolutely correct that there are gender differences in disease susceptibility in all kinds of different diseases, ranging from rheumatic diseases that are more common in women to Alzheimer's disease, which is again more common in women, Parkinson's disease more common in men. When it comes to cardiovascular disease, as has already been said, of course, cardiovascular diseases are overrepresented in younger men in comparison to women, but then, of course, postmenopausal, they are more presented in women. And in the end, more women actually die of cardiovascular disease than men do when we look at the lifetime risk.
So that goes back to Undimed. Now, I'm talking to you at home because do please put in your questions And I've actually got some questions that we've gathered in advance. And now is the moment to ask one from the Camden WI. I hope you're watching Camden WI. So Camden WI's question, and I don't know who wants to take this, I suspect it might be you, Charlotte, is do women with heart disease have different symptoms? And if so, why? Because we've all seen that advert, that funny advert with a man in a very bad shirt with kind of hands coming gripping it. What kind of symptoms do women get?
I mean, just going back to that advert, I think that is the prime example of why we've got a problem here. Because in the advert, you've got a man for a start, and you've got that kind of classical ripping pain, well, it's the kind of constricting pain of that band. And that's what we in cardiology would describe as typical chest pain, typical angina. But actually, the number of patients who present like that is relatively low, and women certainly present much less commonly like that, and are more likely to present with slightly what are described as atypical symptoms, such as shortness of breath or palpitations, feeling dizzy, etc. And even the terminology that's used there, typical, atypical, that is kind of wrong. And by describing the symptoms that women experience as being atypical, that's almost
half the population.
Exactly. It's perpetuating these difficulties, and the difficulties that women therefore are going to kind of have with understanding and recognizing their symptoms at an early stage. And that does, of course, have massive impact. We know that women are far less likely to present early with heart attacks. So we know in cardiology, we describe something called the symptom balloon time, which is the time from someone develops a symptom to the time that they go into the cath lab and have their artery opened. And we know that the shorter that time is, the quicker the artery is opened, the better the outcome in patients. We know that women have a much longer symptom to balloon time, and also daughter balloon time. So doctors are less able to recognize.
That's a big thing, isn't it? Yeah. Because a lot of doctors think you're not menopausal, therefore you can't possibly have heart disease. You must have indigestion, my dear.
Yeah, I think that's definitely true. And in fact, we know that cardiovascular risk factors, although perhaps slightly less common in women, the effect of those individual risk factors are likely to be more significant. So a woman who smokes has got a greater increased risk as a result of smoking than their male counterparts. And so really, doctors have historically not been particularly good at recognizing and calculating risk for women as compared to men, where most of the risk calculators and things are based on evidence from men. And we need more data, both from kind of population and clinical studies, to try and understand these things better.
So Amrita, then it comes that women are given medicines, and women are given medicines that are designed by and tested on men, and not even any old man, but usually healthy young men. So tell me a bit about that and what the issues are there.
Well,
many.
There are many. I just wanted to say one thing though, that when a woman has symptoms or some symptoms that are concerning her and makes a call, if she's having a heart attack, that is the symptom to balloon time. But actually in London, some analysis of the data that's come from the London Heart Attack Centres, of which there are 8, the Pan-London cohort, shows that when you look at men and women, actually the door to balloon time, which is when they arrive at the hospital to when they get their PCI, is the same for men and women. So whilst there are differences globally, actually in London, we seem to do quite a good job of treating women once they arrive at the hospital. That's in London. But in terms of understanding better the differences between men and women, it's true that experimentally at the preclinical level, as well as the early experimental medicine level, that we haven't spent enough time looking at mechanisms and differences in biology. What's clear is that, and we haven't mentioned it so far, is that the way that the blood vessels of women respond to stimuli is different from the way in which the blood vessels of men respond to stimuli. So very simple, important aspect of cardiovascular health is that the inner lining of blood vessels, the endothelium, is constantly releasing factors that keep the blood vessels open, prevent platelets from clotting, prevent inflammation from taking place in the blood vessel wall. the way that a woman and her blood vessels work to enable that protection is different from the way in which male blood vessels operate. We do know that, but we're just not doing enough experimental work to understand the mechanisms and pathways very well.
Is it true that women are more affected by stressors? I mean, maybe Shani has something to say about this as well, that then they react to stress in a different way. And actually, I'm thinking at the moment of the women in Ukraine, you know, under extraordinary pressure and strain. And I would predict there would be an epidemic of heart disease.
Well, actually, the response to stress is different between men and women. And if you're looking at an acute response, for instance, blood pressure changes, it's been shown that there'll be an increase in blood pressure, but actually in men, that this is predominantly driven by the sympathetic nerves that innervate resistance arteries to increase vascular tone, decrease the diameter of blood vessels, so increase blood pressure. But women, their heart rate goes up much more than in men, and that is because of the innovation to our heart, smaller heart sizes, heart rate is much faster. So we actually respond to stress slightly differently. And it's also true that in later life, there tends to be a slight difference in the types of cardiovascular disease that we suffer. There are a lot of women with heart failure, and actually recognizing their disease, which doesn't necessarily have a characteristic that is commonly measured, which is ejection fraction. So
what's an ejection
that's
fraction?
how effective the heart is in pumping blood out of the body. It turns out that women seem to have more of what is called heart failure with preserved ejection fraction than men, but we don't really have very good treatments for preserved ejection fraction. And that's because we don't necessarily understand the pathways as well in terms of that disease. And actually, if it's more prevalent in women, it may be that there's actually not been enough research on women in the first place to help us get effective treatments.
And I'm delighted that we've got Maeva Hay from the British Heart Foundation here with us. And can I just do a quick shout out and say, people think we've conquered heart disease in terms of heart attacks, because we don't really know of people who die of heart attacks these days, particularly younger people. But it's all been pushed up, and there's an epidemic of people dying with heart failure. This has not gone away, and it's a major, major problem. Do you want to add anything on the stress, Shani?
I think what has emerged from the Lancet Commission report was very much about the impact of these types of conditions, the socio-economic, all of the impact on these types of social events. And the impact of it is disproportionately affecting women. I think, as Anita mentioned, there is still quite a lot that is not understood about mechanisms associated with this. But the outcome in terms of effects on women's health is quite clear. And I think that then points now to trying to get the basis of the, I'm not going to emphasize all of the things that Amrita's already described, but there are some very key differences in how women respond to this. And I think addressing those and understanding the basis for it will actually be really important in being able to take forward, either recognizing it as a problem and also for putting in sort of effective therapies to be able to deal with that.
There's a question here, another question from Camden WI, thank you. How do you think we can, is there evidence that women are less likely to seek help for heart problems if they're experiencing them? And I guess that's probably because they think it's something else, or think it's something trivial, and often women are the last on their list of worries. Other people are ahead of them in the queue, as it were. Would that be true?
Yeah, so I think it's a combination of factors. I think it's a combination of the individual themselves, the patient themselves, perhaps not recognizing that the symptoms that they're experiencing may be related to their heart. The clinicians, as I've said, both in primary care and secondary care, aren't quite as attuned perhaps as they should be. And then also within communities, and there are community and ethnic and social differences which can make it more challenging for women to seek healthcare. So it depends obviously where you are, not only in this country, but where you are in the world in terms of cultural access to healthcare facilities, and also language barriers. For example, in this country, parts of East London, where both Amrita and I work, some of the language barriers can really lead to delays in patients being able to seek and to be able to advocate for themselves in terms of healthcare, where they're having to rely on a family member or an external translator to be able to access healthcare, as well as you say, difficulties with carrying responsibility for children, being able to actually access the healthcare on a kind of practical level. So there's multiple different aspects that differ by not only geography, but also by culture.
I want to go back to the drugs thing again, because women, you were indicating, react differently to drugs, the same drugs that are given to men, but they're underrepresented in trials. Why have they been underrepresented in trials? I mean, they are, after all, 50% of the population when I last looked.
And I think they still are.
And they may still be.
I mean, they definitely are underrepresented. We have some of our biggest cardiovascular trials that have taken place, examples CANTOS and COLCOT, that are focused on individuals with atherosclerotic disease. And in those trials, some of the largest, CANTOS had over 10,000 individuals in it. Only 25% were women in CANTOS and 19% in COLCOT. And actually, I don't think, I took a look at a little while ago, I don't think they've stratified their data according to sex to tell us if there were any noticeable differences between men and women in those trials. But it's because of, I think in the large part, it's fear. We've had some terrible health scandals in the past, issues with thalidomide, the worry that you might be recruiting women who could then go on to have children, who might be pregnant during the course of the clinical trial. I think that was has been a legitimate
and of course, the cycles that women have, is that affecting, I mean, it may not at all, but is that affecting the efficacy of the drug, for instance?
Well, you're absolutely right, Vivian. There was a perception that the variability in a response in a woman is much greater than the variability in a response that you're interested in a man. And that is because the woman's cycle, estrous cycle. Actually, there have been a number of studies now that have looked into this and have discovered that this isn't quite the truth. There are meta-analyses, for instance, in the neuroscience community, shown that there's simply the standard deviation around the response that they're looking at is no different for men and women. So those historical views are being challenged. And actually those views have been one of the primary reasons why, even at the preclinical level, it's not just clinical trials, it's the early discovery research. It's focused on using male tissues, male animal experimental models, and females have largely been.
Yes, male rats.
It's true.
Right. I'm going to look at the research side, because how difficult is it to get funding and to do research that's related to sex difference?
I mean, we work on Parkinson's disease and Alzheimer's disease, and as I already said, there are definitely differences between men and women when it comes to more Parkinson's disease in men and more Parkinson's disease, more Alzheimer's disease in women. So when we do any kind of preclinical research, we always ensure that we've got female and male genetically modified animals at our disposal. And that's nowadays, it gets more and more important if you want to get your research funded, and also if you want to get your research published, because a lot of publishers will expect nowadays that you show sex differences and that you also analyze your results by sex. And I mean, it goes even further, as Amrita just said, you should also consider the sex of the cells we are working on. So I work in cell biology as well. And of course, these cells are normally retrieved either from male or female patients in general. And of course, we need to record if these cells are female or if they are male. And of course, we can also consider adding sex hormones to it, so estrogens, androgens, or also progestogens. So in general, there's obviously a lot of work that needs to be done, but I think at least in the science community, I think we already made a good step forward, which of course then needs to be translated also into other preclinical trials, but also, as Amrita also said, phase 1 clinical trials where women are underrepresented, and they are so important when it comes to the safety of drugs. So if we want to ensure that drugs that are thought to be safe in men are also safe in women, we obviously need female participants in phase 1 clinical trials. Because what happens at the moment is that often drugs are taken off the market again when they already have been introduced into the clinic, and mostly because of side effects in women, and mostly side effects in cardiovascular symptoms in women, anything from especially arrhythmias is a very, very common one, but also just other side effects like dizziness or breathlessness or all kind of.
So what you're saying is, there's a common side effect. Arrhythmias are more likely to be the women's side effect that's seen.
But I think really in all the drugs, even drugs that are very, very well established for high blood pressure, for cholesterol, for heart failure, all of the kind of main drugs that we use in our everyday clinical practice, all of them, if you look at the side effect profiles in all the clinical trials, they're much higher, much more common. It doesn't really matter what side effect, they seem to be more common in women. So one of the questions, and I'm no expert in this area, one of the questions is whether it's related to dosing. We all take standard doses based on just whatever maximum dose is recommended in the formulary. It's not based on body mass. So a small Asian woman who's 80 will take the same dose as a 6'5" hulking rugby player if they've got the same condition. And whether side effects are related to that, it's difficult to say, but it must have some impact. Also, we know that body composition, the amount of water and fat that women have in their bodies is different to men. And we know that drugs distribute themselves, and the way that your body deals with drugs, clears drugs, will be dependent on these kind of factors. And all of that is different between men and women.
So tell me, Vikram, the medicines that are used in obstetrics and gynecology, surely those have all been tested primarily on women? Or is it right that some of the drugs, for instance, even that are used during pregnancy and delivery, have not actually been tested extensively on women?
Well, I think in terms of obs and gynae, we might be a bit better there. Because I think many of the medications we do use eventually for female-related health issues are usually given based on weight or your BMI. But of course, it's not universal. There will be still medications, for example, antihypertensives. If you're not pregnant, if you're taking it as a general health as treatment of high blood pressure, then yes, it's not tailored to your weight or your BMI. You would go by the available products and the kind of milligrams of the medication that's available. So still lots of work needed to tailor it to the individual woman based on her weight, based on her BMI, based on her ethnicity. That sort of work remains to be done. We still give estimated doses of medications and rely on the formulations available.
So I'm going to swap tacks here for a moment, because we've got another great question which comes from Vidya in New York. Thank you, you're probably not up yet, or just having your breakfast. Is there evidence that COVID-19 has had a negative impact on the incidence and outcome of heart diseases in women? Anyone like to tackle that? I think it's you again, Charlotte.
Okay, yeah. So we know that COVID-19 has had different effects between men and women. So we know that the severity tends, particularly in the earlier first wave, to be worse in men than in women. And kind of in contrast to that, we know that long COVID is more common in women than it is in men. In terms of cardiovascular outcomes, I think I've actually looked into evidence for this, and there really isn't the data out there yet. There probably will be some that emerges, but it's going to be very, very complex to try and work out whether it's a biological difference or whether it's actually related to some of the socioeconomic, sociological issues that we've discussed before, to do with women perhaps not having the same access to healthcare, being more reticent to go out and seek healthcare, etc. I think it's very difficult to work out. But what we do know is that some of the aspects where cardiovascular disease outcomes did change with COVID-19. So, for example, the time it takes for somebody to get, we're talking about heart attacks again, to get their artery opened up were significantly longer because of delays related to COVID-19. We know that it's more likely that that will have a differentially worse effect on women, but the data isn't there yet to actually prove that. But it'll be interesting to see what emerges.
Fascinating. I just want to go to some of the things that have come out of the Lancet Commission, because that's been fascinating. It's a really terrific document, by the way. Do have a look at it. We're seeing cardiovascular mortality in young women increasing, which is kind of extraordinary. Anybody want to tackle why we're seeing such an increase in younger women?
So I think that there are several factors. I think one of the key things to bear in mind is that we're becoming more and more aware that heart disease, especially coronary artery disease, tends to progress in rather different ways in men as it does in females. Men typically get the more traditional type of coronary artery disease, which tends to affect the larger arteries, the ones that we visualize whenever we do an angiogram, for example. Whereas women tend to get a predominance of very fine arterial disease and the very tiny branches, which are beyond the resolution of an angiogram. So it's quite possible that a woman goes to have a coronary angiogram because she's had very suspicious sounding chest pain, but a coronary angiogram is completely normal, and all the arteries look blameless.
What a fascinating. So it's not just the drugs are not tested on women, but the diagnostics
and this is
which actually is an outrage.
Yes, exactly. Especially because these diagnostic tests are sort of the pinnacle of coronary imaging. You'd expect anyone going for an invasive coronary angiogram, which actually carries a risk of fatality, of doing the test, is going to get an absolute certainty that there's nothing absolutely wrong with your coronary arteries. But thanks to lots of other imaging tests, we have now discovered that even people who have pristine coronary arteries may still have a huge amount of disease involving the finer microcirculation. And we call that microvascular ischemia, or microvascular angina. And women tend to get a predominance of this, particularly if they've got a host of risk factors. And some of the best imaging to look at that nowadays, thankfully, is cardiac MRI. So it's also quite possible that if you have a woman coming to your clinic, even if she's young or if she doesn't fit the stereotype, if she is reporting symptoms which are of concern, particularly if there's an important family background coming with lots of risk factors, even if the angiogram is normal, it might still be worth pursuing additional imaging tests, not just stopping at the normal invasive angiogram. And that means referring her on for an additional test, which is the cardiac MRI, because we now, in fact, have coined a new disease condition, which we call MINOCA, and that means myocardial infarction with no obstructed coronary artery disease. Because these people go on to have.
You had it here first, MINOCA.
Yes. So the European Society and all the experts in cardiology have coined this new disease term precisely because we have now discovered that even in the absence of blockage in your coronaries, you may still have angina or angina-type conditions. And bear in mind that women not only tend to get this prevalence of disease in the finer coronaries, which is missed by angiogram, but they also tend to have, unfortunately, they suffer lots of coronary mimics. And this is a big problem because if clinicians are not aware of them, you can get fooled. And some of these coronary mimics are actually quite serious. So women are more at risk, for example, of dissecting the coronary artery. That's a horrible thing. Your artery actually ruptures along its length. And again, you can do an angiogram and it will be completely normal. And sometimes the only way to pick up these subtle dissections is by doing a CT scan. So you need to have a rather lucid doctor in the middle of the night who's treating this patient to actually suspect that this could actually be a coronary artery dissection, which can cause sudden death. And if you were to discharge that patient without the appropriate test, without the appropriate overnight intubation, then that could be catastrophic. But there are other coronary mimics as well. Takotsubo, which is the broken heart syndrome that was alluded to.
That's where you have the heart that's kind of squashed in a kind of constricted, and it looks like a Japanese pot, which is called Takotsubo.
Yes. So that is the textbook description is usually of a middle-aged female who's just experienced a sort of a life-changing stressor. For example, the death of a partner, or suddenly moving house, or children sitting exams. An important stressor.
Just children.
And typically it's these kind of women who experience a surge in anxiety. There's usually a lot of panic associated with it, and it causes a sympathetic overdrive. The sympathetic nervous system is that part of the nervous system which makes us panic, which is sort of alert, fight and flight response. And it can have an impact on the heart as well, causing the heart to dilate, suddenly becoming weakened, and causes sort of sudden massive fulminant heart failure, which is completely unexpected. And these women sometimes do present. And again, you know, typically there are ECG changes, and if you perform an imaging test, even a basic ultrasound, you will notice that there's something seriously wrong with the heart. But again, these are what we refer to as mimics. So they kind of confound the picture. And this might be one of the reasons why men have a more straightforward path into the cath lab, whereas with women, it's more sort of riddled with all these confounding factors which are there to sort of distract the physician, particularly in a busy A&E with lots of people there. So you can quite understand that you know, the scenario for women might be trickier, and that might explain the heightened mortality potentially, which you were mentioning earlier.
It's fascinating. We only have, what, 4 minutes left. I can't bear it. Because
we have so many questions online as well, but unfortunately we're...
Bold me one question from online.
So we've got one person, anonymous, has actually written it. Is there outlook to create separate diagnostics and treatment or algorithms for heart disease presentation in men and women?
Charlotte.
So I mean, I think all of the guidelines now are recognizing these differences and are including it in the guidelines. I think one of the areas where we definitely need to move forward is thinking about potentially different treatments as well, or considering treatments separately for men and women. We've talked about underrepresentation in clinical trials, but for example, one of the big trials recently in, and we just mentioned this earlier, heart failure with a preserved ejection fraction, a condition that's very common in women. The trial showed that the new drug, sacubitril valsartan, was not effective overall. But actually, when you looked at the group of women, they did benefit from the new drug. So we really need to be in our clinical trials thinking about whether treatments perhaps could be beneficial in women that may not be beneficial across the board. And unless we do that, unless we incorporate that into our clinical trials, we're going to miss the opportunity to potentially find new drugs that benefit women. So I think we should, exactly as the question is asked, we should be thinking about both diagnosis, treatments, and definitions in terms of gender or sex-specific recommendations.
I can't bear it because we've got so little time, but I'm going to give you my famous Vivian Parry magic wand, and I'm going to ask each of you to close us by saying what one thing you would like to do if you had a magic wand, money no object, that would make a big difference in women's health, particularly in cardiovascular medicine. Let's start with you.
I would probably like to create awareness among women that estrogen is the hormone that's really protecting them. They need to think about perimenopause, menopause, because it's an eventuality you can't escape. So plan for it, seek advice when you get to that age, because there's lots of intervention you can have to protect your health after menopause.
So estrogen, your fairy godmother. Charlotte.
I would actually agree along similar lines. It's about education and prevention, trying to prevent women developing cardiovascular disease by increasing awareness that it is a problem. And that's going to involve not only patients, but communities, community education, and actually telehealth, telemedicine, which has improved during COVID. All of these aspects will hopefully improve women's access to health.
Amrita.
I think there needs to be greater inclusion of females and women in experimental studies. And I think we need to be
both doing them and taking part in them, as in more female scientists.
We need to be designing our studies so that there is stratification by sex, and that is both at the preclinical level and at the clinical level. And until we do that, we're not going to really understand what the real differences are between them and women.
And make it easy for women to be able to take part in trials. Gabby.
I think the priority needs to be equitable access to health and care for women as it is for males. And I think with this new paradigm shift towards remote clinics and telephonic clinics, I'm just concerned that the digital inequalities that already currently exist are going to get wider rather than narrower, and that they are going to impact the more vulnerable groups more than anything else. So I have concerns that that is not necessarily for the best for women's health.
Kirsten.
And first of all, I absolutely agree with everything that has been said already. What I think is really important on top of this is that we really use the information we've got already, that all of the information, so all of the information on gender differences, sex differences is disaggregated, and that we also have an input into a computer, for example, deep learning, really using this kind of information later on in clinical trials, but also in preclinical research, so that we've got all of this information already available, because nobody can actually remember all of this information. I don't think we have really got into deep learning when it comes to pharmacokinetics, pharmacodynamics, even though, of course, a lot of people work on it. So I think we really need to connect better with this kind of industry, with computer science.
Shani, apart from a ton of money for the Institute,
a lot of money. But for me, I think that perhaps one of the more important things will be identifying early markers that can help to pick the disease up at an early enough stage, whether it's in men or women, but developing that so that we can actually have effective treatment in order to stop the damage that actually cannot then be reversed. And if we can add a second one, it would be really good to then be able to have sex-specific markers that can diagnose many of the things that were discussed here today, so that women can actually get the treatment they require in order to sort of overcome these hurdles that we still continue to face. We have our institute director.
Stole my thunder.
Perry, please close all of them.
So I think what a great event. I mean, that sounds patronising, doesn't it? I mean, that sounds surprised, but it was actually a really, really
just after
great event. What have we learned? The unders, we just heard. Just a few thoughts that occurred to me during what we've been saying here, that even this conversation has been framed within a particular mindset. We're framing it in the sense of a Western European mindset here. Vivian, you brought up the point about Eastern Europe and what's happening there. Before the terrible events of recent weeks, a woman in Estonia has a 10-fold increased chance of having cardiovascular disease than a woman in France. So this is more than just simply about the science. It's a fundamental reflection of how we live in our societies and of the inequalities that exist even within Europe. We also framed this in the slowing of the decline in mortality, which is true, and we're seeing these worrying trends, particularly amongst younger women, for increased frequency of heart attacks. How do we tackle that? Well, I think you've heard we need more data, we need to understand this better, we need better research. The clinical trials thing, I think, of course we need to do better clinical trials. I think that is changing. But actually I think there's an even more fundamental cultural change that needs to take place in cardiovascular therapeutics, which is that we tend to be very big picture. We talk about side effects. We're actually tackling disease way into its natural history and not tackling the underlying etiology. We're about 10 years, 20 years behind oncology, where oncology has been about the things that predispose to cancer, but also in identifying novel molecular therapeutic targets. And I think we're just on the edge of that in cardiovascular medicine. And that's going to be relevant to both men and women, and perhaps different between men and women. We touched on a few of the sort of sex-specific scenarios which are of relevance to women. A few that we didn't mention, so for example, something like congenital heart disease. Women now live with congenital heart disease and now going on to have children. And there's another one which is, I think, even more common, which is about the transmissibility of risk. So pregnant women. If you have an unhealthy mother, you have an unhealthy child. Gestational diabetes is almost becoming the norm in some parts of this great city of ours. And you're setting up vascular illness in that child, perhaps for the rest of its life. The other thing I would say is that the sex debate, of course, is really important, but even that doesn't occur in isolation. So one of the reasons that we see a different pattern of disease in women is because they tend to live longer than men. As you become older, not only do you get cardiovascular disease, but you get a lot of other stuff. And we're really bad in cardiovascular medicine at thinking about multi-morbidity. All the people that go into trials are generally not the kind of people that, if you're a GP in the East End, that you're treating. And I think that the point about targets for drug doses and so on, we need to have a much more honest appraisal of what we're trying to achieve when we treat people. You take a 79-year-old hypertensive and you drive her blood pressure down, we've got to target, hooray! And the fact that she can't function for half a day because her blood pressure's in her boots, well, that's not important, we've got to target, that's great. So I think, thinking about the trade-offs between quality of life, quantity of life, what actually are the therapeutic goals, and actually maybe talking to our patients and asking them what we think the therapeutic goals should be, rather than the goals that we impose upon them. So as Institute Director, I'm very, very fortunate to work with a great bunch of scientists, clinicians, professional services staff, all of whom work towards the same end, which is reducing the burden of cardiovascular disease. We do that not only by studying disease, but also by studying health. Because I think, again, it was implicit in a lot of what was said today. This binary difference is not true. There's actually a continuum. And it's only by understanding that continuum that I think we can do better at population and individual level. This meeting, I think, thank you, Shane. Shane's been the driver behind this. And I think she's our beacon, she's our vanguard in showing our intent as an institute to tackle cardiovascular disease in all its facets. Vivian, thank you. I'm almost over the fact you forgot me at the end there, but that's okay. That's okay.
So it's a broadcast getting exactly out on time.
That's right.
So.
And you're not a member of the Camden Women's Institute by any chance. So
No.
If
you'd like to ask me, Camden
but thank you for coming today and helping us. And of course, thank you to the panel who I think have given us really erudite and a really interesting discussion. So thank you, everybody. Thank you for coming. Thank you, everybody at home.
Fantastic. So I'm going to thank all of my panel. I'm going to thank you who've been listening. I'm going to thank our splendid audience. And I'm going to leave you with the phrase that you have to keep on saying all the time: underrepresented, underdiagnosed, and undertreated. That is women's heart disease. Go and do something about it. Thank you so much, and goodbye.